speak about the challenges in diagnosis of inflammatory bowel disease, some of the classical presentation, and I will present 4 non-very classical presentation of inflammatory bowel disease. So, there is usually a delay in the diagnosis of inflammatory bowel disease, and this is around 5 months in all pediatric inflammatory bowel disease, a bit less for ulcerative colitis, and around 6 months for Crohn's disease. And usually the delay is prior referral to the tertiary pediatric GI center. So, the most common presentation, or the classical presentation for ulcerative colitis and undeterminate colitis, is usually diarrhea with bleeding, plus minus some abdominal pain. For Crohn's disease, more than half of the patients of Crohn's disease present with diarrhea, and around 45% present with combined diarrhea and weight loss, whereas the classical triad of weight loss, abdominal pain, and diarrhea are only in a quarter of the patient presenting for Crohn's disease. 7% of Crohn's disease patients present with only perianal diseases. So, if you look into the predictors for inflammatory bowel disease and the diagnosis, so if the patient presented with only abdominal pain, this will lead to a remarkable delay in the diagnosis. If the patient presents with constipation and poor growth, this is another predictor for delay in the diagnosis of inflammatory bowel disease. Whereas if you look into bloody diarrhea, or if you look into having extra-intestinal symptoms such as erythema nodosum or erythropathy, this will lead to quick diagnosis. So this is about some of the classical presentation of IBD, and I'm just going to go through some cases of less classical presentations. So the first case is a 14-year-old girl who presented with some gradual reduction in the weight. She denies any GI symptoms apart from some poor appetite and nausea. She was put on multivitamins, and she was treated for H. pylori after some rapid quick test. The child presented to my clinic unable to walk and severely emaciated with a BMI of 13. She looked pale and she was quite tachycardic with cold periphery. On examination, there was some inflammatory ulcers, and as you can see from the picture, the difference between any aphthous ulcer and inflammatory ulcer is you can see the surrounding erythema, and in the middle there is the inflamed area and the pus. The abdominal examination was quite strange. I could feel a bulge and a fullness in her right lower quadrant, and in the perianal area there was some inflammatory skin tag. On examining her lower limb, there was some erythema tracking from the inguinal canal down into her lower limb. Her labs were very abnormal. She was severely anemic. She has neutrophilia. Her CRP was very high. She has thrombocytosis and raised ESR. So we've done some imaging, and interestingly, is this a pointer on this? No pointer, okay. Yeah. Yeah, so, yeah. So, hello? Hello? Yeah. So if you can see this bowel loops, there's quite thickening, and as if there is concealed perforation into her terminal ileum. And if you look into this is the psoas muscle, and there is abscess formation in her psoas muscle. And this is her lateral abdominal wall and the lliopsoas, and there is some pus and abscess formation, and there is a tracking into her upper thigh. So the radiology report is multiloculated fluid collection in the right iliopsoas and the lateral abdominal wall, extending distally into the proximal femur. with circumferential wall thickening and localized abscess formation in her terminal ileum. So the suspicion of a localized contained perforation. This child obviously needed resuscitation, so she received bowel rest, parenteral nutrition, IV antibiotics, CT-guided drainage of her abscess, and after that, after interval 6 to 8 weeks, she received a right hemicolectomy. She did really well after that with maintenance immunomodulator and biologic therapy. So a little bit about lliopsoas abscess and Crohn's disease. Limping can be the initial presentation, and it is a complication of untreated Crohn's disease. Consider other diagnoses like tuberculosis, salmonella, and staph sepsis. So I think one of the take-home messages is to suspect Crohn's disease in patients with emaciation and unexplained weight loss, even if there is no GI symptoms. Look for the GI clues such as the oral cavities, the external anal examination, and the right lower quadrant tenderness. So the second case is a 13-year-old child who presented with lip swelling and mouth ulcers. He has a background history of abdominal pain, a long history of constipation and anal fissure. So, on examination, his lips were quite swollen, and there was some inflammatory ulcer and gingivitis. There was some inflammatory skin tag in his perianal area, in which mom said that this has been there for a very long time. His lab showed some low hemoglobin, thrombocytosis with raised inflammatory markers. He underwent an endoscopic assessment as well as lip biopsies, and this showed erosive gastritis, duodenitis, ileocolitis, and granuloma formation, as well as granulomatous inflammation in his lip biopsy. So this child has orofacial granulomatosis and inflammatory Crohn's disease. He responded really well to exclusive enteral nutrition and immunomodulator. He was on cinnamon and benzoate-free diet as well as prednisolone mouthwash for his orofacial granulomatosis. He relapsed later on, and he's currently doing well on biologic therapy. So just a reminder that lip swelling can be the presenting signs of Crohn's disease, and always consider perianal examination as a clue for IBD. The third case is a 15-year-old boy who presented with nausea, poor appetite, and intermittent yellowish vomiting. He doesn't have abdominal pain, but he just has some constipation. He looked quite pale and thin, but on examining, he has some tenderness in his right lower quadrant. His labs in keeping with some inflammatory changes with low albumin. So in view of that, in view of the tenderness, we've done an endoscopic assessment, upper and lower GI endoscopy. And his upper GI endoscopy was normal, his colonoscopy was normal, but it was really hard to get into his terminal ileum. It was narrow and thickened. And that showed quite deep-seated ulcer, so he has an isolated terminal ileum Crohn's. He has MR enterocolesis to look for a small bowel disease, and this showed 20 centimeter narrowing and thickened terminal ileum with pre-stenotic dilatation, which this gave him the feeling of nausea and the intermittent vomiting. He did really well on exclusive enteral nutrition, immunomodulator, azathioprine, and then he had accelerated biologic therapy to infliximab, and he has good nutritional and symptom improvements. So I think the take-home message from this case is upper GI symptoms, vomitings, is not always secondary to upper GI cause. It could be secondary to stricturing disease lower down. So always consider upper GI endoscopy and lower GI endoscopy if you have suspicion. So the final case is an 11-year-old boy who had pain while he's sitting. He has some low-grade fever and he had perianal discharge. Interestingly, he had the abscess that has been drained 6 months ago. On examination, he has some poor nutritional state, and he does have again another perianal abscess with some induration and erythematous bulging, as well as there was a small perianal fistula sitting at 7 o'clock from the anal verge. His labs shows mild anemia, mild thrombocytosis, and slightly raised ESR. His endoscopic assessment, as well as the surgical involvement for examination under anesthesia, showed abscess which has been drained, as well as intersphincteric fistula in which ceton has been inserted, and his colonoscopy showed patchy colitis with granuloma in keeping with Crohn's. This child did well on exclusive enteral nutrition and antibiotic therapy for 2 weeks, and after 6 weeks, after assuring of the abscess has drained, the child was started on infliximab. So probably the take-home message from this one is in perianal abscess, always think of inflammatory bowel disease. And if you are to drain the abscess and you have such a suspicion, always do a joint GI and surgical assessment under the same general anesthesia. So I hope this 4-case presentation highlighted some of the non-classical presentation of inflammatory bowel disease. So psoas abscess in the first case, lip swelling and orofacial granulomatosis. In the second case, upper GI symptoms with nausea and vomiting. And finally, the perianal abscess.